Okay, well, thank you all for coming. It's the last lecture in a very exciting day. I'm sure you've all had, and you are all looking forward to going for a drink and dinner. And I'm up against Sex and Mel and someone else, so thank you for coming. Possession. So thank you for your dedication to poop here. Okay, so where am I going to start? What I'm going to talk about this afternoon is colorectal cancer, okay? And so I'm going to take you through a little bit about colorectal cancer and what it is and how we can prevent it, because as acupuncturists, I think we can play a key role here. And then I'm going to talk about the service that we set up at Barnet Hospital to give acupuncture to colorectal cancer patients. And then I'm going to take you through some case studies, okay? And and this is really about not so much, I'm not going to say this is how you treat people with colorectal cancer. This is more a lecture about what I learned about these people, okay? And so, and how I reacted to them as a practitioner. So I hope this is helpful and informative to you. And I just want to, upon this presentation isn't quite as polished as I might like it to be, and that I will apologize for that. I'm going to be reading bits out. It's not all in PowerPoint. Some practitioners prefer that. Anyway, I've been recently bereaved, so my energy has been going elsewhere, so that explains that. So, before I start, I want to acknowledge the people who were involved in this, and particularly the funders, the Millie Apthorpe Charitable Trust, without whose money this would not have been possible. At the time I worked, my department, which is the Supportive Oncology Research Team, was part of the Linda Jackson Macmillan Center, which is a cancer information support center at Mount Vernon Cancer Center, which is in Northwood in Middlesex. The consultant I worked with was Dr. Rob Glyn Jones, who is the consultant clinical oncologist and Macmillan lead clinician in gastrointestinal and colorectal cancer at Barnet, then at Barnet, Watford, and Mount Vernon hospitals, and a very eminent man who fortunately is used to do Western medical acupuncture, so he's very supportive of acupuncture for his patients, very supportive of research, and very supportive of me, so I'm very grateful to him. And the staff at Barnet Hospital, who were very helpful always, and a great pleasure to work with. So I have published on some of this work, and I've written 2 case studies. Anyone who came to my case study talk yesterday? Thank you, yes. So there are 2 case studies in EJOM. And I will be referring to one of the cases today, but the rest is not in here, so you might want to look those up and read them. They're very extensive case studies. EJOM were very, very indulgent and let me just go on and really talk about these people in depth and the problems that they were having. This is Rob Glyn Jones, who is my co-author, and I mentioned yesterday that one of the things I did with these case studies was it was not only my approach to the treatment and the patient's reaction. I got the patients to write sections talking about what they got from treatment and what they felt about their treatment, but I also got Rob Glyn Jones to write a section from the oncologist's perspective. So we've got a nice kind of 360-degree perspective of these patients' treatments. So I think they're interesting papers, even though I wrote them almost all by myself, apart from those people. So colorectal cancer is the 3rd most common cancer worldwide for men and 2nd most common worldwide for women. And there are about 1.8 million new cases worldwide in 2018. So in the UK, it's 12% of all cancer diagnoses. It's the 4th most common cancer, just after breast, prostate, and lung. And there are about 42,000 new cases per year in the UK. I'm going to talk a little bit about anal cancer, which is not under the, it's a little bit different from the colorectal cancers, but obviously geographically, physically located. It's near, so we might as well talk about it. 57% of people diagnosed with colorectal cancer will survive 10 or more years after treatment. And survival has more than doubled in the last 40 years. So this is good news. Survivorship is good. And the thing about colorectal cancer, it is one of the most preventable cancers, okay? So Cancer Research UK reckon that 54% of cases could be prevented by improved lifestyle, okay? So I think that's really phenomenal and shocking, okay? And I think as acupuncturists, we can work with our patients to make sure that they reduce their risk of colorectal cancer. And here you can see, so when I was working at Barnet, I would have the patient notes and I would see these photographs. So you see a normal colon here, and you can see examples of rectal, colorectal, and descending colon cancer there, and just how different a healthy colon looks from one that has tumors in it, yeah? And anal cancer here, these are some anal cancer cells. I guess this is the tumor here on the edge of the anus, yeah? So, as practitioners, it's good for us to know the symptoms of these, so if our patients present, we can encourage them to go off and get it checked out. So, colorectal, bleeding from the bottom and or blood in the stools, a persistent and unexplained change in bowel habit, unexplained weight loss, extreme tiredness for no obvious reason, and a pain or lump in the tummy, yeah? Anal cancer is much rarer, okay? But it is also rectal bleeding, itching and pain around the anus, small lumps around the anus, mucus from the anus, and loss of bowel control, okay? So in terms of TCM, what does anal cancer sound like? It's damp heat, isn't it? Yeah. And I think this is more difficult to try and sort out in those terms, okay? In the UK, there's very good screening programs for colorectal cancer. Are you familiar with them? Yeah. And these are, I mean, people get very exercised about how invasive screening tests are. These are completely non-invasive, and it gives you an opportunity to go back to being 2 years old and playing with your poo, right? Okay. Anyone over 60 years old here? Anyone done these? Yeah, it's great, isn't it? Every 2 years.
It's so good when the letter comes back.
Indeed, yes, yeah. Okay, so in England, because it differs in all the UK countries, but between the ages of 60 and 74, the people will get a home screening kit sent to them every 2 years. Currently, it measures fecal occult blood, but this is going to be replaced by a fecal immunochemical test, okay? And the advantage here is that for the FOB, you need to take 3 poo samples, okay, within 2 weeks, I think it is, yeah. And with the FIT, you only need to take 1, okay? So it kind of reduces the mess and fuss, okay? And what this does is it checks for hidden blood in the stool, which can be a sign of polyps or bowel cancer. And the point is to identify bowel cancer early before symptoms develop, okay? Because if you do this, early identification and treatment always means better outcomes for the patients. The earlier you catch cancer, the better it is for everybody, okay? So, and it says about 9 out of 10 bowel cancers, around 90% can be cured if they're found early, okay? So lots of people ignore these, okay? So if you've got patients, try and encourage them to do them, okay? They're a little bit messy, but they are good. It's better to know early on than later on. So what are the risk factors for cancer? Well, for colorectal cancer, diet is a big one, okay? We're going to talk a bit more about that. Being overweight or obese, lack of physical activity is a risk factor, smoking, tobacco, alcohol intake, age, it's a disease of age. Most cancers are a disease of age, bowel cancer in particular. So over 40% of cases occur in people over 75 years. And I think there's another stat that it's like 65% in people 65 years and over, yeah? So it's awfully, but what we're going to see is people in the case studies are people who are less than these ages. Family history, if your parents or relatives have had colorectal cancer, then there's a higher risk. And if people who have who have ulcerative colitis or Crohn's disease are going to be at higher risk of getting colorectal cancer. So anal cancer is quite different because this is 90% of anal cancer cases are linked to the HPV infection, yeah? But also people with a history of cervical, vaginal, or vulval cancer, people who smoke, and people with a weakened immune system, so people who are on immunosuppressants for organ transplant or who have HIV. And again, this is an age-related thing, so 51% of cases occur in people at the age 65 or over. So what we learn from that is that if you really want to avoid having cancer, don't live too long, yeah? So, key lifestyle here. Basically, you want a diet that's high in fiber, so fruit, vegetables, whole grains, and what they like to call healthy proteins, so chicken, fish, and pulses, okay? And if, I think, how did I do that? I think 30% of colorectal cancer cases in the UK are due to low fiber in the diet or could be prevented by having, I think that's how I put that in there, okay. So you want also a diet low in processed and red meat, okay? And so you will be, if you've listened to the news in the last year, you will have heard the great furore about processed and red meats causing cancer, okay? And this is quite confusing because if you read the literature, it's not, you don't have to eliminate those from your diet, but you want to have a reduce the intake, okay? High-calorie food, sugary drinks, and alcohol are also not good for the bowel. So you want to maintain a healthy BMI between 25 and 30%. So I think 11% of bowel cancers in the UK could be prevented if people maintained a BMI that was good. Physical activity is the area where the research evidence is very strong for reducing the risk of bowel cancer, okay? And it kind of makes sense. If you're sitting all day and never moving, everything's going to get just stagnant in the lower jiao, okay? So you want to encourage your patients to exercise. Smoking is also 7% of bowel cancer cases could be reduced, could be eliminated by people stopping smoking and avoiding or reducing alcohol. And the World Cancer Research Fund has a very good website if you're interested in diet and exercise and the research, the evidence base for all of that. They have a very good website, and I recommend them. So, treatment for either of those is surgery, chemotherapy, or radiotherapy, or a combination of any of those. And the problem for many for many people undergoing cancer treatment is they think when their treatment is over, their problems are over, okay? And what happens is that they then have to face something that we don't call them the side effects anymore. These are the consequences of treatment, is how they're referred to in the literature of cancer. And some of these are fatigue, sleep disorders. Fear of recurrence is a big one, okay? So people who have cancer are very afraid of it recurring, and this is something that needn't necessarily diminish over time. I have friends and patients who might be 10, 20 years on from their cancer treatment, and they still say, it is still a source of great fear and anxiety for them. And with my work with cancer survivors, I do find that this is very debilitating, and often, if you're working with them and you've got a handle on their symptoms and they're doing well, they will suddenly spike and everything will go bad again. And often this is linked to something quite simple, an anniversary of treatment, the need for a follow-up assessment with their cancer team, something like that, or even news stories in the news will often trigger this, okay? So it's really, I think it's really important whenever we're dealing with people with cancer to be aware of that and the impact that it can have on their well-being. So you also get mental emotional problems, anxiety, depression, lots and lots of body image issues, okay? So people can have lots of scarring from the surgery across the abdomen. Often they have a stoma, okay, so that their bowels no longer work and they empty the contents of the intestine into a bag. And some patients take to that very well, and some patients just hate it, and it's real problems, okay? Sensory neuropathy, particularly if they have had chemotherapy, lots of gastrointestinal disorders, which we're going to talk about, urinary incontinence, sexual dysfunction. They can have I think the literature says people generally, or often, they might have one, but many people have at least 3 of these, okay? And it is thought that these are worst during the first 3 years after treatment, but they can persist, okay? And people can be suffering from these things 10, 20 years on. So what are these gastrointestinal disorders, okay? So people have bowel urgency, frequency, and incontinence, and they have lack of control, and they have sorry, let me just go back. So they have urgency, frequency, and incontinence. So they may have many, many, many bowel movements in a day, okay? And they may come frequently, they may come in quick succession, they may come throughout the day, okay? They're very inconvenient. They have lack of control, and they often have accidents in private and in public. And some of these can be just kind of discreet, like soiling in the underwear or on the bedding. Some of them can be very horrible in public. So one of the women that I treated at Barnet, who was a very, she was a very elegant woman and very conscious of her appearance, to the extent that she always she came for treatment in full makeup and with her hair done, and on the days when her hair wasn't done, she wore a hat, and she wouldn't take it off during treatment. Okay, so I was treating her in the winter, and we had a hot little airless room, and she would wear this winter hat because she refused to take it off and let me see her messy hair. The point of this is that she and her husband took the tube into London to go out to dinner one evening, and when she came back on the trip home, she just had a complete evacuation of the bowels on the tube, okay? And she said this was very horrible, it was smelly, it was messy, and utterly humiliating for her, yeah? So this is not a nice way to have to live. And what many patients start to do is they start not wanting to leave their house, okay? So their lifestyles become very restrictive, okay? And they become embarrassed about their condition, they lose their confidence, okay? And often what they do is they control it with loperamide hydrochloride, okay, so Imodium, okay? But that in itself has got some side effects, so gastrointestinal disorders, headache and nausea may be common. And there are reports of serious cardiovascular events associated with large overdoses, okay? But the BNF doesn't quantify what a large overdose means. So this is not a nice, these people are cured of their cancer's been taken care of, and they're left with this to live with, okay? So it's not fun. I've worked with lots of kind of different cancers. Each one has its particular consequences, and they're all awful. This is awful in a very particular way. And this is deeply taboo, okay? We don't even with these patients who were having these problems, they don't talk about this, and there's lots of euphemism around it, okay? And this, we don't talk about poo in public, and we certainly don't do it in public, yeah? So this is deep, deep taboo stuff. So our service at Barnet came about because the Linda Jackson Macmillan Center received a philanthropic grant from the Millie Apthorpe Charitable Trust. And the trust said that it was to be used specifically for the benefit of the people of Barnet, okay, so an area of North London. I blessed them for that because nobody else in the, everybody, pot of money, everybody wants it, and nobody could quite make anything work. And so I suggested to my manager that maybe we could set up an acupuncture service in Barnet somewhere and do some study. And so she thought that might be a good idea, and we spent some time trying to work out how to do that. And then she had the bright idea of pairing up with Dr. Rob Glyn-Jones and working on colorectal cancer. And so any consultant, any oncologist that you approach and say, I've got some money and would you like a free service, what are they going to say? So we set that up. And the way I thought it was going to work, so I went to, he had a weekly clinic at Barnet on Thursdays where he saw his colorectal patients. We thought that he had a suite of rooms, and we thought that I would be part of his suite, but in fact what actually happened was I was in another area of the hospital. But this was for outpatients. It was for patients who had completed their cancer treatment, and so they were dealing with the aftermath. And the idea was that we would give them eight acupuncture treatments, and the sessions lasted 45 minutes. Dr. Glyn-Jones would refer his patients into me. And at the time that I was setting this up, I had a colleague in my supervision group who had a hospital-based service in London, and she was overwhelmed. She just had waiting lists for 6 months, and I thought, this is going to happen to me. I'm just going to have such a thriving practice. And so after 15 months, I'd had 16 patients referred into my service, okay? And only 14 of those had started acupuncture. So I was very, very disappointed by this. And there were lots of reasons for that, not all to do with me as an acupuncturist. So what happened was that, Dr. Glyn-Jones was close to retirement. There were things happening in the hospital. His lists were very small. He said he would, he tended to refer his patients that he couldn't offer anything else, that had been offered everything and nothing else would work. So he never called them this, but we would call them heart sink patients, yeah? So these patients that I saw had been through every department in the hospital, had every test, and nobody could help them anymore. What else do I want to say about that? That's probably enough. But so there was a low up. Oh, yes, and the other thing he said was that he would often mention it to these patients, and they would initially say yes, and then they would kind of back off. So there was a fear of having acupuncture there as well. But we set up this service, and the aims were to improve the quality of life for colorectal cancer survivors, and we wanted to see if we could identify potential areas for future acupuncture research, which we never did quite do. And what happened was that this evolved into something quite special, because we had this pot of money. I could keep going there and treating them, and Dr. Glyn-Jones was still there, and so the patients that he did refer and who did take up the service got something that probably nobody else in the world ever gets. They got long-term free treatment, okay? So in the NHS and in cancer centers, everything's rationed, as we know. You get 6 or 8 treatments. These patients got up to 70 or more treatments, okay? So I learned a lot about that because my chief learning is that these people can be helped with acupuncture, but it's a long, slow process, okay, when they are that severely complicated. And I'm going to show you some of those in a minute. They had very complex presentations because, as I said, they had everything that they had things that the hospital and Dr. Glyn-Jones no longer were able to address. They often had comorbidities, okay, so other problems. So often they were overweight or obese. They had most of them had heart problems. A very high proportion had diabetes. And what else did they have? Because there are 4 or 5 things. No, I don't have it here. So they were complicated, yeah. They had lots of other issues. Some of them had possible cancer recurrence or new cancers coming up. Some of them had severe cardiovascular disease. So there were lots of problems. And they were of a demographic, while some of them were professional and many were immigrant, okay, and working class, and so people who wouldn't necessarily also access acupuncture, okay. So this was kind of taking it into a new group of people.
Actually, all research as well, which is quite interesting, that sort of demographic are less likely to be represented in research.
Yes, yeah,
So
yeah,
that's
yeah,
really great.
yeah. So this is, sorry, I've got a little handout here, and there'll be there's probably enough to go around. Okay, so I was very disappointed, yeah, because my friend had this thriving NHS practice where she had this wonderful waiting list, and I was, when I started off, I was driving around the M25 for 45 minutes every morning to go and treat one patient, okay, and that was disappointing. And we built it up by offering these patients more training, more treatment. And then what we did, so I collected a lot of data, as you'll see. Can I make this bigger? I don't know if I can make this bigger. Anyway, you'll see it on the, yeah, okay. So we did some outcome measures because I was looking for ways we could research. So we did the Measure Yourself medical outcome profile. Is everyone familiar with that? Okay, so I don't need to explain it. And then we used some really cancer-specific validated questionnaires, something called the EORTC QLQ-C30, which is a general quality of life questionnaire, and the QLQ-CR29, which is colorectal cancer specific. And then there was another questionnaire called the Lower Anterior Resection Syndrome questionnaire, and then we did a service evaluation for them. And we administered these every 8 treatments. So we, after 15 months, we evaluated this, and what we found was on the MIMOPS, we were getting good scores, okay? So we had, how many did we, I can't quite see this here, but I've got one here that you brought back to me. So we had good data on 11 patients, and the MIMOP scores on their symptom 1 and symptom 2, you can see there's a huge improvement here. It was statistically significant and clinically significant, so the patients noticed a change. Also on their activity, that improved, their general well-being improved, and their overall profile improved. So that was positive, okay? That was good. And what we found was that they had the kind of symptoms that they were concerned with were musculoskeletal pain, bowel function, chemotherapy-induced neuropathy, insomnia, fatigue, tiredness, weak legs, grief, and poor well-being. And then their secondary symptoms were pain, anxiety, worry, concerns about bowel control, post-surgical sensations, chemotherapy-induced neuropathy, respiratory problems, and poor memory. And some of the activities that they were having problems doing were gardening, walking, exercise, social activity, sexual activity, managing stress, having a discussion, and everything, okay? So that's what the patients felt. So that looked good, but we looked at the EORTC QLC30, and we didn't get any changes, any significant changes at the end of 8 acupuncture treatments, which was a bit disappointing. So what we did was we wanted to see what our group, was like compared to another group. So when you develop these questionnaires, you work with the population and you establish something called the norm. So we compared our group's outcomes with the norms of the people that were used to develop the ERCC QC30. And we found that our groups had much worse, they had lower levels of functioning, so they were less able to function, and higher symptom scores than the reference population. So basically, our community was more complicated. Yeah, they were doing very poorly in comparison to the norm, and also with the QLQC CR29. They have a lot of specific symptoms, but the only significant changes that we recorded were changes for stool frequency and dry mouth. And again, our population was doing less well than the norm. So once I knew that, I was kind of heartened, and I kind of could change my approach, because before I felt I had been wading through treacle trying to help these cases that weren't shifting. Yeah, does that make sense? Good, okay. So the learnings I got from this, I'm going to talk through, okay? My mantra became regular habits equal regular bowels, and I'm going to demonstrate that with cases of Hugo and Norma. Pain, no gain, we'll demonstrate with the case of Anna, who also will show us something about the relationship between emotions and the gut. And then the case of Edward. So those of you who stayed the course will get to see Edward's lovely legs, okay? Edward's very lovely legs. I'm very proud of his lovely legs, okay? So I'm just going to, but before I do that, I'm just going to talk about, the idea was to do individualized treatment, which I did, but there were a couple of approaches that were my kind of core approach, and I'll just talk through those that I found very helpful. So one core approach, and was anyone in Marion Fixler's talk? So, okay. Okay, because she was talking about over-treatment and building up as you go along with your treatment. So I'm a big fan of 4 gates, large intestine 4, liver 3. Is everyone familiar with that? Okay. So I was trained at Reading, at Kickham, so integrated 5-element TCM. And there we're taught that the first thing that you do when you treat a patient is you do an AE drain. Is everyone familiar with that? It's treatment on the Bacchian chew points. And as a practitioner in my early years, that's what I did. And it wasn't working for me. I don't know how it was working for my patients, but it wasn't working for me. And so, so I don't know quite how I got to this, but I started doing this as my first treatment, 4 gates. And I kind of stuck with it. And it works for me, okay? And I find it very effective. So I like it because it's simple, it's 4 points. I like it because what I didn't like about an AE drain was I was working at the back of the patient, and I want to see my patient, particularly new ones, I want to have eye contact, I want to see what's happening for them. They get to feel quite strong needle sensation, if that's your bag, okay? And this is relaxing, okay? So a first treatment for a patient is never very relaxing if they've never had acupuncture before, because it's just a weird experience. But this is potentially very relaxing. So this is where I start, and then I might, depending on the patient, I might add in yin tang to calm the shen. And then if they're doing well with that, in this case, with these patients with their bowel disorders, I was fairly generic. I used stomach 25, spleen 15 to regulate bowel function, regulate qi and eliminate stasis in the lower jiao, and stomach 37 because we know that's indicated for all intestinal disorders, and then maybe I would do points for the patient, okay? So I wasn't rigid about this but it was kind of my starting point, and it gave me information. So if I did this and they came back and they talked about I could see it in the treatment room, how they reacted to that, but then I would build up with their response the next week. What did that do for you? And then just build up. The other thing about this, So does anyone work with patients that are referred to them by medical? Yeah. They're scared, aren't they?
Yeah.
Yeah. What is this acupuncture? I don't know what it is. A medic has referred me, so it's going to be really scary. I know about needles. I've had chemotherapy. I know about needles. This is going to hurt. Yeah. So they're really anxious when they come to you. Whatever their other problems, they're anxious because they're coming and having acupuncture. And I think this is kind of, if in a cancer center, I don't know what it's like. I think it was exacerbated by them coming back to the hospital. We were in the hospital. Yeah.
And talking about emotional, we had a patient just drive past the hospital 9 years later, and he went.
Yeah.
And he was just driving past it.
Yeah.
So,
Yeah. Good. I always feel I feel guilty. I feel guilt and shame doing this.
You have to start somewhere, and this is what we always, we start somewhere, and then you can add and take away, but you have to, without getting the feedback from that first treatment, and they are terrified.
Yeah. So I relied on this a lot. The other thing about these patients is they really don't like you touching their, here, because this has been very traumatized by the surgery and things, okay? So often it would take a little bit of discussion to use that, and in general they were fine with it, but some of them didn't want to be needled in their tummy. Why do I keep doing this? Okay. So I did that. So we started this in September 2015, okay? And this is how I kind of went along, eventually evolved this and went along with this. And then last year I came to the BAXI conference. Did anyone go to this? Yeah.
I have this one.
Yeah. So this is C.T. Holman, and he was talking about treating emotional trauma. By that time, I'd worked with these patients now. I should have known, but it just kind of gelled. All of these, whatever other stuff is going on for these patients, they are hugely emotionally traumatized by their cancer experience and by the way the bowels are letting them down. So he has this, because he has this 3-step process for dealing with emotional trauma, and mostly I stuck around step 1, gathering the chi. So it's pericardium 6 bilateral, spleen 6 bilateral, Ren 12, and yin tang. And then you can move on to step 2, and what I did, because we all kind of take on other people's stuff and distort it to our own way of treating, I didn't move on to his step 2, but what I did was I would eventually start incorporating these points into the treatment. And so from probably, I guess, the last 6 months of running that clinic, this is what I used. I used this a lot, and I was just kind of experimenting to see what would happen with it. Patients loved it, okay? They just went away. I think 4 gates is really relaxing. This was relaxing beyond that. Yeah, they really responded well to that. So when I talk about these patients, some of them, this was their acupuncture diet that they got from me. But not, okay. The other thing I did was I gave them, where have they gone? Bowel diaries to keep. Can I, sorry, I beg your pardon. So they kept bowel diaries. And these were very, very helpful. And some, it's like, everybody has a different approach to these things. Some people were absolutely religious about them. Anna, who I'm going to talk about later, said, I think about you every time I go to the toilet, she said. And I looked at her, and she said, yes, she said, I go to the toilet, I wash my hands, and then I fill in my bowel diary, and I think of you. So these were really helpful, and particularly, for really tracking, you will see how helpful they were for tracking something, but they were also helpful just for tracking progress over a long time, and we'll talk about that. Do I need to say anything else about that? Yeah.
You know how acupuncture is attributed to just normal peristalsis, the moving of the bowel. Did that ever come up in your treatments? or...
How do you mean?
So even when we were just doing distal points, you often get the rumbling of the bowel.
Yeah, yeah.
So did you ever have an instant where just not trying to move the bowel, if that made sense, I know you had stomas and things, but, just, did it ever come from your feet?
Did it move the bowel during treatment?
Yeah.
No. So they would get the rumbling and stuff,
yeah.
but nobody ever had an accident, and nobody ever had to say, get me out of here. So that never happened. No. And yeah, that's a good question. Okay, so I'm going to move on to some cases. And who did I say I was going to go? And this is where I start reading from my books here. I'm sorry. Oops, where is that? Okay, so Hugo. And Hugo was kind of... Hugo was a difficult patient, yeah? But actually, going through his notes, he wasn't quite as difficult looking at the notes than he was working with. But he was a really nice guy, okay? He was a young man. He was 38 years old when he had his first acupuncture treatment with me, but he was diagnosed with, and I don't have his diagnosis here, with colorectal cancer at the age of 35. Okay, so this is young, okay? He was referred to me, Dr. Glyn Jones referred him to me because he had catastrophic episodes of opening his bowels. That is what was in Dr. Glyn Jones's letter. And he would have his bowels opening 15 to 20 times in an evening, okay? So just imagine that, okay? So his cancer history, he was diagnosed at the age of 35. He had preoperative chemoradiation followed by a laparoscopic anterior resection, so surgery, okay? He had an ileostomy, and that was reversed about a year later, okay? So he had returned, he had a stoma, and then and that was reversed, and he had bowel function. And he said the bowel function had been bad for 3 to 4 months after that reversal, and then improved. But 1 to 2 times a week, he had these catastrophic episodes of 20 times a night. And they started after eating, particularly a big meal. The stool started off solid, then turned loose. This would go on for 3 or 4 hours, and after that, he would be left exhausted. He didn't suffer from leaking or diarrhea. And he managed it with, why can't I now remember the loperamide? Thank you very much. Yes. And then after one of these extreme episodes, he wouldn't have a bowel movement for 2 or 3 days, okay? A normal day, when he had those, he had 6 to 7 movements in the morning after eating his breakfast. Now, he said that he wasn't, that on the whole, he said, I am alive and haven't got an ileostomy bag. So he was prepared to live with his bowel problems because of that. Nevertheless, this wasn't good. His prior history, he had a history of severe anxiety, which he would have in acute episodes, and he would go on and off citalopram. He maintained that fear of cancer recurrence wasn't a contributor to his anxiety states. And some other food, he started grazing. Okay, so if he ate a lot, he would have these terrific, it would trigger his bowels, so he tended to graze. He called a big meal fish and chips, and just watch his diet evolve here. Anything more than fish and chips, a burger was a big meal. Anything more than a sandwich. He was trying to change his diet. But he couldn't eat any fibrous food, so he couldn't eat salads and things like that. In our initial consultation, he said he drank a few beers when going out, and we're going to revisit that, okay? He had an interesting tongue because it had a nice brown coating. I don't see those very often. Anyone see brown coatings on tongues very often? Okay. And I'll come back to some of the things that I learned about him. He was a nice guy. He was a very nice young man. He was very erratic, and that wasn't help. So the first treatment I gave him was 4 gates, and the second was 4 gates, and then I added in stomach 25 and stomach 37. And why did I do this? I didn't. So, and then he had some, I think I decided he had heat in the intestine. So on treatment 3, I tried to resolve the heat. I used large intestine 11, large intestine 2, and stomach 44. Nourish the fluids with Ren 12, Ren 4, spleen 6, and kidney 6. That's a lot of points, I see. And regulate the bowels with stomach 37, and calm the Shen with Yin Tang. And I also taught him a breathing exercise, okay, because he was quite, I think he was quite stressed about something. I taught him a breathing exercise. So, and I repeated this in treatment 4, and he felt he was making good progress. He'd had a good week, but he realized that he wasn't helping himself with his own routine, so that came from him. But nonetheless, his sleep was improving, his diet and bowels were variable but improving, and he was having clusters of bowel movements. He found the breathing exercises great, and but I noted in my notes, I wrote that everything is completely random about him, okay? So it was very hard to fix him, okay? And he started talking about how much loperamide he was taking, and he was just managing stuff with lots of loperamide. And then, of course, he would manage the loose bowels, but then be constipated for some time afterwards. So the other thing I just need to say about his bowel, so the impact of his bowel movements, even on a normal day, he said, when I go out in the morning to work, I have to plan a route where I know I can access toilets, okay? So he had to be able to access a toilet quickly. So then I didn't see him for a month, and he had an eventful month because he'd wound up in A&E, which was initially thought to be a twisted bowel, but then they decided was gastroenteritis. He'd been in France for 2 weeks. So, and this is where I started to develop the picture of his extremism. So he was into extreme sport. He was doing 10 to 12 hours of cycling a day. He was rock climbing. And he said this would exacerbate his bowels for 20 to 24 hours, but he was happy. He just called that runner's trots, yeah? So we must have, I guess at treatment 4, we must have had a discussion about loperamide, because he said he was trying to limit his loperamide to six a day, okay? Because before he had just been popping them like candies. And I went to the BNF and I looked at it and I said, you know, these do have side effects, which he hadn't been aware of. So he was improving his diet. Would you like to know what he was living on? Because we have seen what we need for good bowel function. Okay, cream cheese bagels, chicken or beef burgers, omelets, and smoothies, okay? But that's what he could tolerate. So he felt that acupuncture was moving in the right direction, and because he'd had this but he was feeling quite off after this attack of gastroenteritis. So I used gallbladder 41, triple burner 5 to expel the pathogen. I regulated the bowels with stomach 25 and stomach 37, and regulated the stomach chi with stomach 21. And then saw him 3 weeks later. And he said with his life, various things were coming together. He was taking care of his diet. He was eating those simple staple foods, but he wasn't feeling right after the gastroenteritis. But he said, it all feels more manageable and controllable, and his loperamide was reduced to 4 to 5 per day. So I went back to 4 gates and Yin Tang, and also used Ren 12 and stomach 21 for that stomach discomfort. And then I didn't see him for 2.5 months. You see how this is going, yeah? So he had been off hiking in a developing country. His guts were right off, okay? So I can't imagine what that trip must have been like, because they were out in the sticks. So, and he would have these frequent episodes. And the diet there wasn't good. He said the diet was mainly bread, ham and cheese, so, and of course meat, bread, ham and cheese, and of course meat was something that he found set off his bowels. So when he came back, he had seen Dr. Glyn Jones, who referred him to a gastroenterologist. But the nice thing was he'd met a girl, okay, who was an Ironman marathon runner. So it was about that time that we started talking about his belief systems and why and he was really interesting, because he was a lad and he couldn't make changes because he was a lad, okay? So a lad went out and drank beer and went for curries with his mates and didn't get in food and ate takeaways and didn't go shopping and didn't have breakfast, because that wasn't what a lad did, and he was really hooked into this. Somewhere in here, I started to have discussions with him about how much alcohol he was drinking, because he drank every day, and of course, alcohol is a risk. Drinking alcohol is a risk factor for colorectal cancer, and so. He was not very keen on that, and then one day he just said to me, I won't be able to reduce my alcohol. And I said, why is that? And he said, well, I have a family history of alcoholism. So it was very interesting, the construct, and it was very interesting because his work was change management, and yet he was incapable of trying to make changes in himself. So my notes there are, Richard knows that he needs to change, and then at this point, I had started using the trauma protocol. So I did pericardium 6, spleen 6, Ren 12, and yin tang for him. I saw him a week later. He said he was struggling with his lifestyle, but he was agreeing to fortnightly treatment, which I suggested to him. And we did the trauma protocol again. And we discussed continuing to support the changes that he thought he needed to make, but wasn't capable of implementing. So we had a discussion around that. So then I saw him 2 weeks later, and I suggested that he started having, so at that treatment, I had suggested that he started trying to have breakfast every day, every morning. And of course, that was the thing. Well, I'll have to get in something will have to be there in the morning. And I said, yes, you just have to get organized. Well, I can't do that because I'm a lad. So I talked him around, and he did it for 2 weeks, and he found it doable and helpful. He'd had one catastrophic incident. He'd had some mushroom and truffle pasta, and he had 36 hours of gut disruption. And then I didn't see him for another month. So this was after we agreed to fortnightly treatment, yeah? So I didn't see him for another month. But he was positive. He thought he was definitely getting better. He was having fewer catastrophic events. Things were more regular. So things were positive. And I saw him a week later. He'd had another catastrophic incident and a difficult time with his food. And then I didn't see him. He was booked in for another treatment. He canceled it. He was going off to see the gastroenterologist, and he said, thank you, that was helpful. I found it helpful. And what this crystallized for me was this idea of regular habits equal regular bowels. He needed, I think that had he been able to regularize his life, to eat regularly, and to cut down on the alcohol. He drank enormous amounts of alcohol. He told me once, I do 8 pints a night. Does anyone drink 8 pints of beer a night? And I said, this must have an effect on your gut, because it's got to have an effect on your gut, right? Yeah? help me out here. Yeah. And he just said, no, he said, I can do that. That is absolutely fine. So there was a resistance there that I didn't get to. Pardon? Well, yes, thanks. Well, thank you. Okay, so, but that crystallized it for me, and I was able to use it for Norma, where we had much more success, okay? So Norma was 70 years old, okay? And she was referred for bowel frequency, anxiety, and Dr. Glenn Jones said she's not able to tolerate conventional medicines. Having said that, she was on quite a cocktail of conventional medicines because she had cardiovascular problems, so she was on the Holy Trinity for that. And she was diabetic, and so she was on a lot of medication for that. And codeine she was taking to solidify her stools. So her cancer history was in August 2015, she discovered a lump. From November to Christmas that year, she had chemoradiation. I guess she didn't have surgery. I don't see that there. And then the following year, she had a pacemaker installed. In 2018, she had some polyps removed from the womb, and she had shingles. And prior to that, in 2014, she'd had a heart bypass, okay? So she had some quite complicated health issues. She wasn't overweight. She'd been diagnosed with type 2 diabetes in 2005, so she was under the care of a diabetic nurse. So on presentation, she said she wanted better control of her bowels. She said at that first meeting she stopped wearing panty liners, so she'd always worn a panty liner, but she'd had an accident, and her bowels were better when she didn't eat. So guess what she did? She didn't eat, yeah? So her urgency was what she described as liquid poo, and it was horrible. And she never knew where and when it would happen. Her bowels were very variable because she could also get constipated, or she would go frequently, so 4 times in the morning and often throughout the day when I was seeing her. She sometimes got pains, and that was a sign that her bowels were going to move. And she said to me, "It's just not knowing what my bowels were going to do." Now, Norma was lovely. She was also extremely anxious, okay, and she would kind of overload herself and then get anxious about it. And she was also what she described as an old-fashioned marriage or a traditional marriage, yeah, okay. And I think she was quite afraid of her husband in a way. So this was a problem. But she was very active. She loved dogs, and so she walked dogs. And this was a problem because she couldn't get out and walk the dogs freely because she needed access to a toilet, yeah, in case one of these episodes would come on. So our goal that we agreed was to reduce the number of bowel movements, and she didn't really mind how many bowel movements she had at that stage, so long as she had them all in the morning so that she could free up her day to do other things. Her diabetes, she was on a Novamix 30 Flexipen insulin and metformin, and she was on codeine to address the diarrhea. So guess what her diet was? I said she didn't eat, but we have to eat to sustain ourselves, so what did she eat? She woke up in the morning, had a cup of tea and 3 biscuits. She had a little bit of breakfast, some cereal and milk or some toast and honey. She had a mid-morning coffee break, and she had 3 biscuits. For lunch, she would have a Rivita with something on it, and maybe some fruit or yogurt or an Actimel, and 3 biscuits. And in the mid-afternoon, she'd have a cup of tea, and she'd have 3 biscuits. And she didn't have an evening meal, but she had 3 biscuits, yeah? What do you think that does to someone with, I couldn't believe it. Diabetic on that, yeah. So I was very, very concerned about this, okay? Anything else? She said her appetite was poor. Yeah, it would be, okay. She didn't eat meat. She had some salad occasionally. She couldn't eat nuts or onions because and seeded fruits, so tomatoes would really set her bowels off. She cooked a traditional meal for her husband every evening, but she didn't eat it, yeah. And so lots of cups of tea, 6 to 8 cups a day, 3 biscuits each time. So our journey through treatment, okay? So again, she was one of these people that came but was afraid of having acupuncture. And so we did 4 gates and yin tang, and she tolerated it quite well. The second treatment, she must have showed up a week later. She showed up stressed and tearful. And what was happening was that they were having their bathroom remodeled, okay? And their son was doing the work for them, so he was doing it kind of in his spare time. So this poor woman with her unpredictable bowel movements was having to, I think they had a trailer or something that had a toilet in it, so she was having to leave the house and go climb through this trailer and go to the toilet there. So this was not good. But anyway, so I started discussing the importance of good diet, and she was going off to see her diabetic nurse the next week, and I really asked her if she would discuss what she should be eating, because I just couldn't understand that she didn't understand she shouldn't be eating what she was eating. So treatment 3, she came back. She was still very stressed about this bathroom, but she was starting to feel that things were improving. And I was just doing 4 gates, and I was doing this gallbladder point here. I can never remember if it's 14 or 13. It's 13, isn't it? Yeah, thank you. Yes, okay. I always write it down as 14, and I know that's wrong. Okay. And she said that after her second treatment, she said she felt lovely after her last treatment, and it lasted into the next day. So we're starting to get some changes here. Treatment 4, she'd had a terrible week. It had been their wedding anniversary. They'd had a Chinese takeaway, and that had just set everything off in her gut, and she'd had nausea. But she said I feel wonderful when I leave the treatment room, okay? So that's good. So more 4 gates, yin tang, gallbladder 13 to just... So at this stage, really what I was working with was trying to get a handle on her anxiety. And this is what I told her. I think we need to deal with your anxiety before we can deal with your bowels here. So between the 26th of July and the 13th of September, that was those 4 treatments. And she came in the 13th of September. She had a lot going on, but she was feeling more relaxed. And her sugar levels, her blood sugar levels had gone down. So she was advised to lower her insulin. She was trying to eat meals and really struggling to reduce the biscuits, yeah. But her bowels were improving, and she felt they were more organized, okay? So they were happening more in clusters in the morning. So I then started incorporating points for the bowels, so stomach 25, stomach 37. And she didn't kind of get the hang of keeping a bowel diary, so it was really hard to analyze that. But overall, things were better. Her sugar levels were remaining low. She was improving diet. By treatment 6, she was eating an evening meal, and she was trying to reduce the biscuits. And so she was overall feeling more positive. And what I discussed with her at treatment 6, she had lots of stuff going on, these dogs that she needed to walk for people. And so I tried to discuss that maybe things might be easier if she tried to allow herself some time for her bowel movements in the morning. So just to sit there on the toilet and kind of retrain the bowel by sitting there. I don't know how well she got on that. So she progressed, and at treatment 8 on the 4th of October, I changed the protocol to gathering the qi. She loved that. She just loved that. And every time I put the needle into Ren 12, she said, oh, I just feel that. She could just feel that emanating through her body, so she really liked that. And by that time, she was replacing some of her biscuits with toast and Marmite. So at treatment 8, so that would have been a review. And so the aim that we set, she wanted her daily bowel movements she wanted her bowel movements all in the morning, okay? And she wanted, so just to have them. I don't think she didn't mind how many she had, just so long as she had them then. And what I had her do on the bowel diary was that for every day, if she had a day that she was happy with, I asked her to put a smiley face in, and we would count the smiley faces up at the end of the week, yeah. So that week she had 3 smiley faces out of 7. By treatment 9, we started trying to reduce her codeine, and by treatment 10, she came in and she said, "Can acupuncture have an effect on my husband?" And I said, "What's happened?" She said, that's right, I have to save that for later. Treatment 10, her husband had started to notice a big difference, and he commented, and he noticed that she was having fewer accidents and was less stressed, and so she was very happy with that. And I always think it's a powerful moment when the partner, significant other, starts realizing the difference, yeah. So by treatment 14, that was the beginning of December, she said she no longer needed to rely on Loos in the supermarket when she went out. So she was starting to get some control and some confidence. And then we had the Christmas break, and I came back, I saw her on the 10th of January, and she's had very bad bowels over Christmas. What do you think she did over Christmas? Sorry?
Biscuits.
No. They just ate Christmas cake and mince tarts. Yeah? So that just had a disastrous effect. This was really important for her to see this, because from this she learned in a very definite way how much controlling her diet and having a good diet was related to her bowels, yeah? So that was when and by that time I had my session with Hugo, so every time I saw her, I got her to repeat after me, regular habits equal regular bowels, yeah? So that, yeah, and we went back to 4 gates. So January was a bit up and down, but by the end of January, she was upbeat. The GP had reduced the metformin. She was... yes, and then that's when she came in and said, "Can acupuncture change your husband's behavior?" Because her husband had started to change, and he was washing up after the evening meal. She said, "This has never happened. I'm in a traditional marriage." So this was good. So in February, she went on holiday, and she had a catastrophic event in Tesco's. She said it was the worst she'd ever had. And she kind of got demoralized and lost her regular habits. That morning, she was going to cancel her appointment, but her husband urged her to come, so he kind of bought into this in a big way. And 2 weeks later, things had changed for the better. She said she was more relaxed than she'd ever been. I think her meds were further reduced. She wasn't taking codeine in the morning. She was eating much better, 3 meals a day, and very moderate biscuit intake. And then the 20th treatment was her end of treatment. That was the end of March. So she had 20 treatments over 9 months. And she said at the end that she felt confident that she could go out and not have an accident. She said, "Acupuncture has helped in so many ways. I feel so much better for it." And her last 2 bowel diaries were smiley faces across every day. So she did very well. And I hope she's still doing very well. How are we doing? We're ending in 20 minutes, right? How are you guys doing? Is this doing it for you? So Anna, so very quickly through Anna. Anna was lovely, and she taught me 2 things. She taught me that with the bowel stuff, you're not going to, well, I certainly didn't make progress with her bowels until I got rid of her pain, okay? And I'll tell you about her in a minute. But also, she had a very interesting episode of, she's a very interesting illustration of emotions and their power on the gut. So Anna was age 50 when she was referred for acupuncture in November 2017. And I just need to tell you a bit about just about her personality. Anna had a smile. You know, when she smiled, I swear, the sun shone in 6 counties. She had the most exquisite smile. She also had a frown that was equally powerful, okay? And she frowned every time I needled her. She just hated acupuncture needling, and it was a real struggle. But we got on very well. She had 70 treatments with me from November 26 to March 2019, and it really changed her life, okay? So she was diagnosed at the age of 44. She started acupuncture at the age of 50, is that right? Because it was 10 years after she was treated that I saw her, I thought. Maybe it was 8 years, okay? So she'd been diagnosed with squamous cell cancer of the anal verge in May 2009, and she'd been treated with chemoradiation. And this was horrible for her. She said, now, the other thing I have to tell you, she was from another country, so English was her second language, and she could speak enough to get by. Communication was really difficult, so kind of getting the kind of detailed information that we want was quite a struggle. And she didn't have a concept of like today and yesterday and the day before yesterday. It was today, and I think it was before today. So you get this, if you were trying to pinpoint exactly when something happened, well, it was before today. So it was very odd. So communication was quite challenging. Anyway, so this, after this chemoradiation, she said, so this is why I'm bringing this up. She was burnt, and she lay in her bed for what I understood was 8 months with these burns, okay, and great pain from this, okay. So it left her with a very poor quality of life. So at her first acupuncture treatment, she reported that she was unable to walk more than 200 or 250 meters due to a constant stabbing pain in her back. She also experienced sharp pains in her legs when walking. She was unable to go upstairs without support. Pain disrupted her sleep at night. She was tired all of the time. She had a family of 3 young children and a husband who was also incapacitated by chronic illness. And I think he also had some post-traumatic stress disorder because they came from a country that had a civil war. So in addition to that, okay, she suffered frequent uncontrollable and urgent bowel movements. Okay, these seem insignificant compared to the 2 that we've seen before. She was recording 5 to 7 movements today with frequent accidents, wind, and bloating. So all of this seriously affected her quality of life. Her shopping and housework were challenging to her. She wasn't able to do more than minimal activities. So she attended for acupuncture weekly, and initially I focused on relieving the pain. And I don't have the details of what I did. Lots of things with her. At times I used, because she was very hard to needle, and I think, I don't know, do you find this, people who are in pain are often really sensitive to the pain of needling? Because I'm not a brute. I'm sure I'm not a brutal needle insertion. And it was just a bit, I'd put a needle in and she would yelp, and this frown would develop, okay? But through this, we loved each other. She came. I remember when she first came, she said, well, I have to come for acupuncture every week for the rest of my life. And I said, no. But there were times when I thought we would be at this forever because it was uphill work. Now, so I have to confess, I didn't make a big inroad on her pain with acupuncture. And so in April 2017, I trained in another therapy. I tried that with her. That was amazing. It worked. I'm not going to talk about it now because we're talking about acupuncture. And when that happened, so we reduced the back and leg pain, and she could sleep better. Her mobility improved. She started to carry out her daily tasks with fewer restrictions. And once we could do that, I could start working on her bowels. So that's when I went to the 4 gates and the stomach 25 and stomach 37. basically. And so one of the nice things about this was once we got rid of the pain, one of the things she always wanted to do was attend a business college course. She wanted to go to college and study business. And so in the spring of 2017, she enrolled on a course. She felt confident enough to do that. And by the time we got her to the autumn when she started going, we had her bowels improved enough that she could manage going to college for 2 days a week. And that was just, that was just fantastic. That was one of the greatest things I think that's ever happened to me and to her. So she said, I want to be normal, I want to work, I want to walk. And so we continued treating her, and at the end of her treatment, she said, I'm very satisfied about the acupuncture because I had very bad back and leg pain. The back pain is completely gone. The leg pain is much better. I am happy because I can do many things because of this acupuncture. So she had 70 treatments between the beginning of November 2016 and the end of March 2019. And when we kind of assessed this, she had probably 8 acupuncture treatments for every year that she had suffered these consequences of cancer, the 8 years, yeah? So that's, I think in the NHS we want to do these quick and dirty treatments for, quick treatments and have the immediate results, and I think that is kind of an example of how long it takes, but it can work. So the thing that I wanted to say about her and the diaries. So she was the one who kept the diaries and thought about me every time she went to the toilet. And so her diaries were showing progress, and they were really good, and we were getting her down to 4 movements a day, and she was happy with that. And she came in one day, and she said, my bowels are all over the place. And we looked at the diaries, and she had 12 movements or something over 2 or 3 days. And this was most unusual for her. I'd never seen that in her pattern. So I kind of went through my list of questions and, have you changed your diet? Have you been ill? Anything like that? And it wasn't like that. And what had happened, she had a very difficult domestic situation, and I cannot reveal the details, but this had flared up hugely. And so all the emotions around this had just hit her bowels, right? Which is what you would expect. But this was a very, very graphic illustration of this. And so once I knew that, it was very disturbing because what was happening to her was very disturbing. But we got back on top of it. So I guess that just made me really realize that this gut-brain axis and the emotions. So I began to think more, because I had been always thinking about dealing with anxiety in these patients, whatever they were presenting and their physical symptoms. And I think that just confirmed it for me, that it's important to deal with those emotional things. And that what it really brought home to me was the power of our emotions on the gut. Yeah. So I guess what I'm trying to say is I'd been trying to think of the bowel problems as a kind of separate problem as a result of the cancer treatment, which in part it was, but of course cancer patients have the same and some more emotions, I mean, what are our own bowels like when we're emotional, yeah? If we're worried, we're stressed, how do they behave? So it just brought that kind of relatedness back to reinforce that with me. Okay, so very quickly, I haven't really developed this, but these patients start off with a bowel dysfunction. They have fear of recurrence, so every kind of little symptom will make the bowels get worse. It will increase their anxiety. The bowels get worse, so you can get this kind of vicious cycle. Does that make sense? Yeah. So if you kind of can start unraveling the emotional impact, you might have a good effect on the bowel. So I promised you Edward's legs. So Edward is written up in one of these case studies, and he He was 61. He was referred to the acupuncture service for some swelling of his legs that developed following treatment for anal cancer the previous year. And he was a person who was in generally good health, but he had this swelling. And you can see, these are the pictures he took before he started treatment. He said that the swelling, so he had, so after he was treated, he had surgery and chemoradiotherapy. And then he went on a long cruise to recover, and his legs blew up, as he said, okay? And so his oncologist, Dr. Glyn Jones, thought this was lymphedema that was a consequence of the radiotherapy. And he prescribed him diuretics, okay, that relatively, and the doctor said that relatively controlled the swelling within 7 days. But Dr. Glyn Jones referred him to me to see if acupuncture could be of further help and whether it would permit either lower doses or even stop the diuretics. Now, Edward didn't like the diuretics. He was a lorry driver at the time, and he just couldn't do his work because he had to keep stopping and going to the loo. So he wanted to get off these diuretics. So So he'd had some improvement before he came to see me. When he started to see me, the swelling was confined to the lower legs, ankles, and feet. But it increased during the day. It reduced when he put his feet up in the evening. And it was accompanied by a pulsating feeling in his feet with throbbings and feelings of tightness. And this was worse after standing for long periods of time. Now, he had a pair of desert boots, and he loved his desert boots. And he couldn't wear his desert boots. So this was heartbreaking for him. So the diuretics reduced the swelling. He found them difficult to tolerate. And he also, the side effect of the diuretics was breast tenderness. Okay, so he had real breast tenderness. So just in terms of, I'm not going to go into too much detail of this. The issue with this was is this lymphedema or was it chronic swelling? And where could I needle? Okay, so because if you know my work, I don't needle into a lymphedemic area. So Dr. Glyn Jones, although he didn't write it, talked to me about this guy having lymphedema. And I do a lot of work with the British Lymphology Society, which is the professional body for lymphedema experts in the UK. So I kind of know a little bit, and I had access to a lymphedema nurse, so I could check this out with her. So I say, essential to developing Edward's treatment plan was to ascertain as far as possible whether the swelling was edema or lymphedema, as it's recommended to avoid skin puncture in the affected area, or at-risk area for lymphedema. So Edward's swellings, in my view, did not conform to the signs that indicate a primarily lymphatic cause, which are the swelling does not reduce if the limb is elevated overnight. Well, his swelling did reduce then. And diuretics do not improve the swelling. Well, diuretics were improving the swelling. So and exercise and movement improved the swelling. Well, his got worse with exercise and movement. So I discussed it with the lymphedema nurse. I didn't discuss it with Dr. Glyn Jones, and I needled him I needled him everywhere that needed needling. So my general protocol here for this was Giovanni Maciocia in his Channels books has a protocol that he calls promote transformation, transportation, and excretion of fluids. And basically that relies on opening the Ren-Mai, so lung 7 and kidney 6. And if you do it the Giovanni way, it's gender specific. So in a man, lung 7 is on the left side, kidney 6 is on the right side. Ren-9 to stimulate metabolism of fluids, triple burner 5, and spleen 9 to resolve damp. And we did this, and I added some points for breast discomfort as we went along. Now, Edward had 20, about 20 treatments, I think. We didn't need that many treatments because probably by about here we were doing okay and everything was under control. But I wanted to get him into the lymphedema service because I wanted him to have proper stockings, lymphedema stockings, so that we could make sure that this was kept under control, even though I wanted her to assess it to make sure that it wasn't lymphedema, but I wanted him to have some support stockings, yeah. And the oncologist and his registrar both tried to refer him into the service. He was never seen by the lymphedema service. But the good news is that Edward and I maintain contact, and he just says that was his legs at the end of treatment, and they stayed like that for the last year. So that's good news, yeah. So I think that is our time. Are there any questions or comments? Yep.
Do you know the crew cohort study? It's a colorectal wellbeing study. I used to run it.
Oh, right, okay.
At Southampton University, and I also supported the anal cancer development on the EORTC.
Oh, right, okay.
So I know Teresa.
Oh, okay, okay, great, okay, yeah.
So, but I'm actually really impressed that you spoke about anal cancer because it's something that it's, we don't talk about it, and I think people do think it's the same as colorectal. I was just wondering how many people you had who had anal cancer and how many people had colorectal cancer?
I don't know.
In this,
I don't, because I haven't gone.
Yeah.
So we did that analysis
Yeah.
when we did it, but I didn't subsequently analyze it. But certainly Edward had it.
Yeah.
Anna had it in the margin, in the anal margin. So does that qualify as anal? Yeah. So those were two. Yeah.
Yeah, because it is really rare actually, and it is. It's just something that it's not a cancer that people are really aware of.
No.
People do kind of shove it into the colorectal bracket.
Yeah.
But I think there's massive, there should be an increased awareness of it actually, but it is more taboo than colorectal.
Yeah.
It's so horrible.
Yeah.
But I'm really impressed as well that my PhD looks at lifestyle.
Yeah.
And colorectal cancer, and so it's quite interesting because I think if you actually do kind of support patients through making a change, because it's so hard when people have got suboptimal health behaviours to start with, then to try and get them to change. But what you've done is you've obviously seen them through that, and so it's like a supported change. And you can see, automatically the difference that makes, and that actually it's coming from somebody who, you know what you're talking about, and it comes, that it kind of helps the patient to understand that they should make the change. I don't think just saying to someone, well, you need to do this, I don't think it really works.
No, and I agree. Yeah.
Supported them through that, so I think it's really good. Yeah, it's great.
Thank you,
Really
thank
good.
you. So what I haven't touched on was a lot of the lifestyle and the physical activity. So if you read the first case study, you'll hear about how I had, because I really wanted to get all these people moving and get them active. And so just the way I encouraged them to get active. So, okay. So thank you very much for your attention, and I hope it's been helpful and interesting. These are my contact details, should you ever need them.
You've got another clap,
Good.